Tim, thanks for the kind introduction, and thank you so much to the organizers for including me. It's great to be in Providence. I actually spent a summer in Providence doing cancer research before I started medical school. And the real reason I was here, I was chasing a Brown undergrad who I ended up marrying later on. And so it's fun for my wife and I to have a chance to come back to Providence for this weekend. So the topic for the talk today is the role of radiation therapy for soft tissue sarcomas. And I'll give a brief general overview for radiation therapy for those of you that aren't familiar with the field, and then talk about some of the data that support the principles of using radiation therapy for soft tissue sarcomas, and then review a couple case presentations. So this has been a particularly difficult year for radiation. This is a picture of the ongoing crisis in Japan, the nuclear power station that's spewing radiation. And there's a lot of concern because of the radiation dose, both to the workers that are there as well as the population in the surrounding towns and cities. The dose of radiation for the workers has been estimated at 400 millisieverts per hour. And there's very good data from the atomic bomb survivors that those that have over 100 millisieverts per year will have an increased risk of cancer incidence. And there was some discussion about medical exposure to radiation, and you can see for a CT scan, that's on the order of 10 to 15 millisieverts per scan. And of course, the occupational limit for radiation workers is 50 millisieverts per year. Now, in the field of radiation therapy, there's also been quite a bit in the news of medical accidents that have happened. So here's an article taken from the New York Times a year ago. The title was "Radiation Offers New Cures and Ways to Do Harm." And this is a picture of a 43-year-old patient who died as a consequence of a radiation accident. It says here, a New York City hospital treating him for a tongue cancer had failed to detect a computer error that directed a linear accelerator to blast his brainstem and neck with the errant beams of radiation, not once, but on 3 consecutive days. And just to show you the complexity of these kinds of treatments, this is the intensity modulated radiation therapy. So here on the top left is the kind of open radiation field, and with the modern treatment planning that's now available, we can use multi-leaf collimators to shield part of the field and treat very small parts of this open field with radiation to sculpt the radiation dose around a critical target like the brainstem. And what happened in this case, due to both software and hardware issues as well as human error, was this patient was treated throughout the whole course of his treatment with the whole field open and received significantly more dose than the physician intended. So these are kind of the big problems that can happen with radiation therapy, and it's really one of the reasons that patients need to be managed, and specifically we'll talk about sarcoma today, but also cancer patients in general, and need to be managed with a multidisciplinary team that have expertise. And I think all of the speakers today are representing institutions with that kind of expertise. So the NCCN guidelines for sarcoma say that it's essential that all patients should be managed by a multidisciplinary team with expertise in sarcoma. This is the group of clinicians that I work with at Duke that includes orthopedic oncologists, surgical oncologists, radiation oncologists, medical oncologists, and pathologists whose primary interest and clinical focus is taking care of bone and soft tissue sarcomas. And so for the principles of radiation therapy, we see our patients together all at one day. So a patient will come in, they'll meet with the surgeon, they'll meet with the medical oncologist, they'll see the radiation oncologist all together in one morning or afternoon, a set of consultations. Patients need an MRI usually of the tumor to assess its local extent. Patients generally will have a core needle biopsy to establish the diagnosis, and then the relevant staging studies are performed. Frequently, that includes a CT scan of the chest, which is often the most common site of metastasis for soft tissue sarcomas. And then we have a multidisciplinary conference. So every Thursday morning, we discuss all of our new patients, where we get to review the imaging together with our sarcoma radiologists. We all get to look at the pathology together, and then we formulate a treatment plan as a group. And the typical treatment plan for many of our patients with sarcomas of the extremity involves limb-sparing surgery with radiation therapy. And there are different types of radiation therapy. There's teletherapy or external beam radiation therapy. There are a variety of different types of radiation modalities. Usually we use megavoltage X-rays, but charged particles such as electrons and protons can also be used to treat soft tissue sarcomas. And then there's also radiation therapy at a very short distance called brachytherapy, and this is usually delivered with a placement of temporary catheters at the time of surgery, and this can be delivered with low-dose rate sources or high-dose rate brachytherapy sources. However, there are certain situations where we will recommend limb-sparing surgery alone, specifically for small, less than 5 centimeter tumors, often when they're low-grade and superficial to the fascia. A good oncologic surgery is often sufficient therapy. And there are also some situations where radiation therapy alone is the optimal treatment. This usually happens when a patient has a tumor in a very challenging location for the surgeon, say a head and neck soft tissue sarcoma that's not resectable. We will either treat with radiation therapy alone or sometimes combination radiation therapy, chemotherapy. And then there are some situations where we've used permanent interstitial brachytherapy as well as an alternative. And I'll present one case presentation of this at the end today. When patients then request radiation therapy, usually with external beam radiation, they come to our department, and the first step is a procedure where we do an immobilization. And here's a patient. You can see the treated leg has been immobilized with a thermoplastic material here to keep the leg in the same position each day. A CT scan's performed for simulation, and then our job is to contour the tumor and the normal structures that we want to avoid. And here's a picture of a CT scan from a patient that I took care of this past month. She has a large myxoid liposarcoma here, contoured out the tumor, the gross tumor volume, also contouring the ovary, which is an organ that we want to avoid. And for a tumor like this, we can actually treat this with a relatively simple field arrangement of opposed oblique fields, well covering the tumor and avoiding the critical normal structures. This is an example of brachytherapy where catheters are placed within the tumor bed at the time of surgery, and we can then place radioactive seeds within the catheters to deliver radiation focally to the tumor bed, generally 5 to 6 days after surgery is completed. So what are the rationales for using radiation therapy? How do we know that it works? And I will be echoing some of the studies that Dr. Brennan led and discussed this morning. So it really wasn't that long ago, just a few decades ago, where amputation was often standard of care for patients with extremity soft tissue sarcomas, and really work that from Dr. Rosenberg and Dr. Brenner and others at the NCI really helped to change that with this randomized controlled trial. Only 43 patients were enrolled. 27 underwent limb-sparing surgery with postoperative radiation therapy delivered as 50 gray with a boost of anywhere from an additional 10 to 20 gray. 17 patients underwent amputation with no radiation therapy. And as Dr. Brennan highlighted, there were a few more local recurrences with the limb-sparing surgery. However, the overall survival was similar between the two groups, and this helped to establish limb preservation as a standard of care for most patients with extremity soft tissue sarcoma. Now, one possibility was that the limb-sparing surgery alone was sufficient to provide cure for these patients, and the radiation was just added on without any benefit. And so in a follow-up study from the NCI, patients were randomized. In this group here, 91 patients with high-grade sarcoma, 47 received postoperative radiation therapy after limb-sparing surgery, 44 had no radiation therapy, and there were also 50 patients with low-grade sarcoma, and approximately half received radiation therapy and the other half didn't. In this case, the radiation was delivered with a 45 gray fractionated regimen with an 18 gray boost. And as you can see from these data, the group that had no radiation, approximately 30% had local failures, whereas the group that received external beam radiation after surgery, very few local failures were found in this study. And this will be a recurring theme from the data presented. Although local control was improved in this study, there was no impact on overall survival from the addition of radiation therapy. And so to summarize this important trial, single institution study from the NCI in Maryland with 141 patients, postoperative radiation versus no radiation therapy. Local control was improved with external beam radiation therapy, but overall survival was not significantly different. In addition, the team led by Dr. Brennan at Memorial Sloan Kettering also did a prospective randomized study utilizing brachytherapy. Here, 164 patients were randomized. Half received surgery plus brachytherapy. The other group had surgery alone. And as was already discussed this morning, the group receiving brachytherapy had improved local control, but there was no difference in overall survival. And so to summarize this study, local control here was 82% with radiation therapy, 69% without radiation therapy, but similar rates of overall survival. And one question that might come up is when is brachytherapy utilized versus when is external beam radiation therapy utilized? I think that there are some clinical situations where brachytherapy can be highly advantageous, specifically if you're treating a local recurrence after previous external beam radiation therapy. The local control rates with brachytherapy here in the 80% range are a little lower than some other studies where external beam radiation therapy is employed, and I think that's in part due to the challenge of covering all of the target volume with an implant. Often external beam radiation therapy can provide a more uniform coverage of dose distribution, but when the geometry is favorable for an implant to put catheters in, it can be a very effective treatment. And then I'd also like to highlight this additional study out of the NCI Canada, which compared preoperative radiation therapy versus postoperative radiation therapy reported by Brian O'Sullivan and colleagues in Lancet in 2002. This was a multi-center prospective randomized trial. 190 patients were randomized. 88 received preoperative radiation therapy with 50 gray. 94 patients received postoperative radiation therapy with 66 gray. The primary endpoint here in the study was a wound complication, and this table summarizes the data for the primary endpoint. One thing that's quite remarkable is that in the upper extremity, wound complications were quite rare regardless of whether the patients received radiation therapy or not before surgery. However, in the lower extremity, the rates of wound complications were significantly higher if those patients received preoperative radiation therapy. The group followed this work up, looking at the late effects following radiation therapy, and what they found is that the risk of a grade 2 or greater complication for subcutaneous fibrosis, joint stiffness, or edema was higher in the postoperative radiotherapy group. And so to summarize this trial, wound complications are higher, particularly in the lower extremity soft tissue sarcomas, when treated with preoperative radiation therapy. I tell my patients, whatever the surgeon tells you, if you have surgery alone, I'll double your risk of wound complication. It's very low in the upper extremity, and I double that risk to a very low number, but in the lower extremity, which can be approximately 17%, we'll double that risk to 35%. However, for most of my patients, I think preoperative radiation therapy has some benefits because it has lower doses of radiation and is to a smaller radiation field, and this means that there's less late toxicity from radiation therapy. So again, the numbers here from the NCI Canada study, pre-op radiation therapy, 32% risk of greater than grade 2 fibrosis versus 48%, and decreased joint stiffness as well. And the local control rates in this trial were quite good in a multi-institutional setting with 90% local control rates. So this is a debate that goes on and on, even despite this important randomized study. Some institutions, such as at Duke, prefer preoperative radiation therapy. Many other institutions routinely use postoperative radiation therapy. Pisters and colleagues have had a nice review on this, describing the trade-off and the balancing between these various sequencing, but in general, the advantages of preoperative radiation therapy are that there's lower radiation dose, smaller radiation field size, which results in fewer late effects, reduced fibrosis, and reduced edema. However, this comes at the expense of increased wound complications. And so if I'm seeing a patient that has diabetes, maybe has a frail heart that I'm worried about, and if they were to have a significant wound complication that could require stay in the hospital and perhaps a second operation, then for that patient we may prefer postoperative radiation therapy. But for a young patient who I'm more worried about perhaps the late effects of radiation therapy, preoperative radiation may be advantageous. And so we do customize this on a case-by-case basis. So I do want to tell you about the recently closed RTOG 0630 trial, which I was fortunate to be the radiation oncology co-chair for. This is a phase 2 study to determine the effect of reduced radiation volume using kind of our most sophisticated and advanced image-guided radiation therapy techniques, and looking at the late effects at 2 years, specifically comparing our data set to the results from the NCI Canada study, looking at grade 2 or greater lymphedema, subcutaneous fibrosis, and joint stiffness. This is a simulation CT scan on the left with the large proximal thigh soft tissue sarcoma, looking at the isodose lines from the radiation field, and image-guided radiation therapy utilizes onboard imaging, so we can either use X-rays or, in this case, a cone beam CT scan to have target localization prior to each fraction of radiation delivery. And so here you can see the radiation dosimetries is superimposed on the cone beam CT scan just prior to therapy, and it matches very nicely the planned radiation field design. And this trial just recently closed with meeting accrual of 100 patients, and we're now await the late effects data to see if using tighter fields, which can be done using image-guided radiation therapy, provides any advantage in terms of reducing late effects from therapy. And so I'll close by just showing two case presentations. Here's a patient with an upper extremity undifferentiated pleomorphic sarcoma. She received 50 gray of preoperative radiation therapy and underwent a limb-sparing surgery. And here she is a couple years later, and she continues to do well with very good function of her upper extremity, as well as continues to be without evidence of disease at this point. And so I think this is an example of kind of the evolution of sarcoma therapy from many decades ago, where this patient would have likely had an amputation, and she now has a very good functional outcome and also control of the tumor. Sometimes we get patients that are more challenging than this, and this is an example of a patient I took care of. He's a 68-year-old retired pediatrician who was treated in 1991 for a nasopharynx cancer, and his treatment was 75 gray to the primary tumor, 60 gray to the cervical lymph nodes, and 38 gray to the supraclavicular lymph nodes, given in a BID fractionation fashion. And he had post-radiation therapy chemo that included cisplatin, bleomycin, and methotrexate. So he presented to me in 2007 with a mass in the right trapezius, and was found to have a pleomorphic myogenic sarcoma. And so his treatment was more challenging because we were treating a tumor that was in the field of radiation from his nasopharynx treatment, and this makes it more likely that he could have late effects or complications from his radiation and surgery. And so this is an MRI showing the tumor here, and we treated him with twice-a-day radiation therapy. I elected to use 1.25 gray twice a day, trying to spare the normal tissues. However, just before he was due to have the tumor removed, he presented with transient ischemic attacks to the hospital. And his workup revealed that he had occluded, bilateral internal carotid arteries that were not amenable to bypass. And this is also likely a complication from his prior radiation therapy 15 years ago. And the surgeons that I was working with at the time were very aggressive, but they felt that he was not a surgical candidate. And so he'd received an inadequate dose of radiation for tumor cure, and therefore I elected to treat him with a permanent radioactive iodine implant. This is very similar to the kind of radiation sources that are used to treat prostate cancer with brachytherapy. And so I used a CT-guided needle placement to deliver 70 seeds to the tumor for a total dose of 55 gray. And here's just a couple images from the CT-guided placement of the needles. And when the needles are drawn back, we leave the seeds in place within the tumor. And here's some CT images here, looking at pre-treatment on the left. Here's the tumor. This is the seeds at 1 year, the seeds at 2 years. And this patient was followed with a PET scan, and you can see the primary tumor here prior to treatment, 1 year out, and now 2 years out, the PET scan's now cold, and he continues to be controlled. So this is an example of using radiation therapy alone to provide local control for a soft tissue sarcoma. So I'll summarize by just saying that for patients with large, deep, intermediate to high-grade soft tissue sarcomas, limb-sparing surgery and radiation therapy is often a useful combination therapy. Radiation therapy increases the rates of local control, but has not been shown to improve overall survival. Preoperative radiation therapy and postoperative radiation therapy have similar rates of local control, about 90%, and preoperative radiation therapy does increase the risk of wound complications, but has less long-term sequelae. I'd be happy to take any questions.
Again, I'll remind you, if you have any questions, please come up to the microphones in the center aisle. So Dr. Kirsch, Dr. Brennan brought up the concept of the silent majority, which is something we all struggle with. We all want to provide our patients with a therapy that's more likely to benefit them than cause harm. And so we all go through a selection process with our patients. Can you say a little bit about how you evaluate your patients and select them for radiation therapy or not?
Sure. I think this is always a challenge. I think that patients that have good oncologic surgery, we know that the majority of them don't have any microscopic residual disease left behind. This is really an area of research interest that I have, trying to develop intraoperative molecular imaging to be able to detect those patients that do have microscopic cancer left behind. But that work's still in mice and dogs and is a little bit away from being a clinical reality. So really we focus on the staging variables. So is the tumor superficial or deep? Is the tumor large or small? Is the tumor high grade or low grade? And for the low grade, small superficial lesions where the surgeon really can get around the tumor and has a good fascial plane to work with, we'll often just observe those patients and not give radiation therapy. But for tumors that are deep to the fascia, that are large and high grade, most of those patients we recommend radiation therapy unless there's a contraindication.
Thank you. Dr. Mackey.
David, thank you for the lovely talk. I'd just like to have you comment on a particular issue in terms of radiation therapy. Just like every surgery is probably better done with a robot, and I say that facetiously, everybody wants their radiation done with proton beam radiation. Can you comment on situations where it may be helpful? Everybody's clamoring for it. It's the new wave of treatment, but it doesn't seem like it's particularly useful except for very limited circumstances.
Yeah. So the question was, what's the utility of proton radiation therapy versus X-ray or electron radiation therapy? Protons are a special type of charged particle that delivers the same biological dose of radiation, so it doesn't cure more patients than X-rays, but it does allow the because of the large size of the particle and because it's charged, it only goes a certain depth and then stops. So the big advantage, the physical advantage of proton radiation therapy is that there's no exit radiation dose, whereas with an X-ray, the radiation goes in and goes out the other side of the patient. And so there are situations where, specifically for pediatric patients, where protons can be a big advantage because the cumulative dose to non-target tissues can be substantially less than with X-ray therapy. One of the challenges is that you can have an advantage on paper or on the computer that's a physical advantage, but that may not translate into a clinical advantage for many patients. So there are a number of proton facilities that have now popped up around the country, and they're treating a lot of prostate cancer patients. And I think they're going to be hard-pressed to really show that there's an advantage for those patients. You can churn through a lot of prostate cancer patients pretty quickly with 2 fields in a treatment, whereas to treat a patient with medulloblastoma that requires anesthesia because she's 5 and may take an hour and a half to do 3 or 4 matched fields, whereas the medulloblastoma patient probably would really have a big advantage when you treat with craniospinal irradiation and not have exit radiation dose. Now, in terms of soft tissue sarcomas, I think that or sarcomas in general, I think that an advantage of protons might be with chordomas, where you need a very high dose of radiation, specifically base of skull chordomas, where the tumor is right next to the brainstem, and you really need to exceed the tolerance of the brainstem dose to get control of the chordoma. There's clearly, I think, a role for it in brainstem chordomas, and I've treated a handful of patients when I worked in Boston with protons for soft tissue sarcomas, and there can be some advantages for select patients, but I don't think as a routine, protons offer a big advantage for soft tissue sarcomas. Yes, sir, in the back.
Yes, Harold Wanabo, very nice presentation. What about the value of sensitizing chemo with your neoadjuvant? Years ago I was involved with the Southeastern group. We had some trials in which we did neoadjuvant chemo plus the radiations you described for the large grade, high-staged, bulky lesions and so forth. And I was always impressed with the tremendous response, oftentimes even a CR, but you did pay a price, and so I wondered if you balanced those.
Sure. So that's a great question. The question is, what's the role of combining chemotherapy with radiation therapy? So when I worked at Mass General Hospital, our standard policy was for patients that presented with high-grade sarcomas greater than 8 centimeters that were deep, those patients received upfront preoperative chemoradiation therapy. And this was a combination of adriamycin ifosfamide-based chemotherapy. It's quite a tough regimen to get through. The RTOG attempted to do this as a national phase 2 study, and there were much higher rates of toxicity seen in the multi-institutional setting than what had been observed at Mass General. So that's kind of been an approach that many institutions have shied away from. I think, though, for patients, I had a patient with an intrapulmonary sarcoma that was right up against the aorta, and it was going to be a very challenging tumor for the thoracic surgeons to resect. And for that patient, we treated with concurrent radiation therapy and ifosfamide chemotherapy. And so I think that there are select situations where concurrent therapy is advantageous. But in the standard extremity soft tissue sarcoma, where we have local control rates of 90% with radiation therapy alone, I'm not sure that the price of additional chemotherapy is worth it. But I think the main issue for our patients is that we don't have very good effective systemic therapies, and the current agents of chemotherapy options are really rather limited. And so I think that we need more targeted therapies, more ways to treat microscopic metastases, and hopefully the next generation of therapeutics will be better.
Thank you very much, Dr. Kirsch.